Hello everyone and welcome to part one of a several part series about an introduction to mechanical ventilation. My name is Austin Kaiser. I'm a flight paramedic and the clinical educator over in Region 1 for California. Part one of this several part series here is called The Tale of Two Strategies, and that will make a lot more sense here over the next several slides. Some of the things we'll be covering during this talk, we're going to understand different modes of mechanical ventilation. We're going to break down and understand the four main ventilator settings when you're being introduced to mechanical ventilation, and then we're going to talk about basic ventilation strategies. Specifically, we're going to talk about two. So before you ever turn on the ventilator, we have to talk about what our goals are for this mechanically ventilated patient, and it really depends on what the patient needs. Do they need protection? Is this a severe asthma patient that failed non-invasive that we had to intubate? So it really depends on what our goal is for this patient, and our goals can be described as a strategy for this patient. There are two basic strategies in mechanical ventilation. The first is our obstructive lung patient strategy, and those are your patients who are either actively obstructed due to exacerbation of their COPD or asthma, or somebody who has some sort of obstructive problem that is making it very difficult for them to exhale. We'll be going over that strategy in part two. In part one, we're going to just talk about the protective lung strategy. Some people refer to it as the lung injury strategy, and this is where we're going to be using our higher PEEPs, higher respiratory rates, lower volumes, in order to help protect that patient from any existing lung injury. When you turn on the ventilator, the first decision that you have to make after deciding your strategy, which we're going to be doing the protective lung strategy in this presentation, is what mode of ventilation we're going to be using. There are two basic modes. There are many advanced modes like APRV and things like that that you will learn as you continue on in your kind of journey for becoming a ventilator expert. But when you're first learning mechanical ventilation, it's generally okay to just stick to these two modes. The first mode is assist control. Assist control, essentially, the easiest way to explain it is if you don't want your patient taking a bunch of spontaneous breaths for any reason, assist control is generally your mode. Or you have a patient that is not spontaneously breathing almost ever. Assist control is a great mode. The next mode is spontaneous intermittent mechanical ventilation, which is a mouthful, so it's very commonly referred to as SIMV. And if you have a patient who is taking spontaneous breaths, SIMV is a very good mode of ventilation for these patients because it allows them to take those spontaneous breaths with a pressure-supported breath, like a BiPAP breath, instead of a full machine breath. All right, so assist control. So what does assist control mean? It means that we are going to set a tidal volume for our patient, an inspiratory time, a respiratory rate, and we are going to dial in an appropriate PEEP and FiO2, and the patient is going to get at least those things. So if you set a tidal volume of 550 with a respiratory rate of 16 breaths per minute and a PEEP and FiO2 of 8 and 40%, the patient is going to get at least 550 milliliters of volume 16 times a minute with a PEEP of 8. If the patient takes a spontaneous breath, then the machine is going to give them a full machine breath. So if that patient wants to take a 17th breath that minute, that is going to give them a full breath at 550 milliliters with a PEEP of 8. Meaning that the patient does not have to work very hard in order to get air, in order to get that 17th breath. They really don't have to put any effort into it. The reason that assist control is the mode we use for somebody who's not taking a lot of spontaneous breaths is because if you really start to take a lot of spontaneous breaths on assist control, where you have these large volumes, you can end up stacking air in the lungs and creating an obstructive problem. All right, so what does SIMV mean? Essentially, we're going to start with the same settings as we did with assist control. We're going to dial in our tidal volume, we're going to dial in a respiratory rate, and we are going to dial in an appropriate PEEP and FiO2. The difference between assist control and SIMV is that with assist control, if your patient takes a spontaneous breath, they're going to get a full machine breath. With SIMV, if the patient takes a breath, they are going to get something called a pressure-supported breath, which is generally going to be a lot smaller than a machine breath. And you can see on this graph down below, you have these three larger breaths right there, and those are the machine breaths. Those are the large machine breaths at a tidal volume of whatever you've set, your 550 milliliter tidal volume. But this patient is taking quite a few little breaths, trying to initiate a respiratory cycle between the machine's set respiratory rate. And on SIMV, instead of giving an additional, we can see five breaths to this patient, we are simply giving 5 little pressure supported breaths. So we can see that the volume is a lot smaller, it's a much shorter breath. It just tends to make the patient more comfortable if they are trying to generate a little bit extra minute volume without really affecting our minute volume to the point where we may have to give them, smaller or less support or smaller breaths in order to not breathe off all of their CO2. So this is just a really nice and comfortable mode of ventilation for a lot of our patients that are trying to take a little bit extra every minute. So let's look at our ventilator settings. Does not matter what ventilator you're using. Pictured on this slide, you can see the Hamilton T1, which is the ventilator that a lot of our Northeastern programs use here at PHI. In California, we use currently the Revell ventilator, but it doesn't matter which one you use. If you understand the basic concepts of mechanical ventilation, you can apply them to any ventilator. And here are your 4 basic settings. The first is tidal volume, the size of breath we're going to give. We can see that pictured in this, we have a tidal volume of 490. We have our I time, which for this patient, for adult patients, we're typically going to start off at 1 second. Respiratory rate is pretty obvious, how many breaths per minute we are going to be delivering. Pictured, you can see that the respiratory rate is dialed in at 12, which we are going to talk a lot about the appropriateness of that number here in just a few minutes. And then we have our PEEP and FiO2. You can see that on the photo of that Hamilton that the PEEP and the percent oxygen are in fact 2 different buttons. However, we should consider these one single button on the ventilator as they do affect the same aspect in mechanical ventilation. They both affect oxygenation in our patient, and so we do try to use these in tandem with one another to both help with available oxygen in the alveoli and help to improve our compliance and our surface area. So they do affect the same thing, and we consider these really one single button on the ventilator. All right, so let's look at tidal volume, button number 1 on our ventilator. So big volumes are not good for our patients. Even if the lungs are not injured in some sort of traumatic way, big volumes are very injurious, especially as you try to put 10 milliliters per kilogram or more into this patient's lung. It is just not good, which seems very counterintuitive because we can really fit 60, 70, 80 milliliters per kilogram of our body weight into our lungs. We have a very large lung capacity, but in a normal breath, we're actually only using about 1/20th of our total lung capacity in our tidal volume. And when we are breathing for somebody on a ventilator, we want to do the same thing. We want to generate that 6 to 8 milliliters per kilogram of their ideal body weight into their lungs. And why do we do this? It's because most of the people that we are ventilating in this protective lung strategy have some sort of infectious process or some sort of consolidation in the lungs. And they don't have a lot of available room to get air into those spaces. And so titrating down your volumes to that 6 to 8 milliliters per kilogram is very beneficial to your patient, and it's been shown by ardsNet and many other studies that that is the appropriate route to go. All right, so like I said, the tidal volume range for our patient is going to be 6 to 8 milliliters per kilogram of something called our ideal body weight. Ideal body weight is incredibly important to use for our patients. We absolutely do not want to be using their actual body weight. The size of your lungs is not dependent on how large or small you are as far as your weight goes. It has solely to do with your height and your sex. So if you take a 5'10" male, it does not matter if he weighs 400 pounds or if he weighs 150 pounds. That 5'10" male has an ideal body weight of approximately 75 kilograms, and that is what we need to base our lung volumes off of. So 6 to 8 milliliters per kilogram of ideal body weight, and if you have a 5'10" person who weighs 75 kilograms, you can do the math, but that would be your tidal volume range. So what does tidal volume mean for our patients? It means protection, and we've really already stated that in the last few slides, that we are going to be giving 6 to 8 milliliters per kilogram of our ideal body weight into our patients, and the reason that we do that is because we know that those volumes are typically safe for our patients. If for some reason our pressures are too high, we can go down on our tidal volume in order to continue to protect our patients. We're going to revisit this protection concept here in just a few minutes, but we'll just kind of let that percolate for a few. In advanced strategies, you can absolutely use tidal volume to affect ventilation. Remember that ventilation is not just how fast or slow you're breathing, it is also the volume of air that you are putting in and out of your lungs every breath. And so if you go up or down on your tidal volume, it will affect ventilation. But in basic ventilation strategies and basic ventilation management, we do not tend to adjust tidal volume to manipulate ventilation. So when to adjust tidal volume? We know that if we set a tidal volume of 8 milliliters per kilogram of ideal body weight, and we are seeing that they are not being well protected because pressures in their lungs are too high at that volume, then we are going to go down on our tidal volume. And we'll, like I said, revisit that here in just a few minutes. Setting number 2 on the ventilator is your I time. In old ventilators, we would adjust either an I time and an E time, meaning your inspiratory time and your expiratory time. We may have had to dial in something called the inspiratory flow rate. But in modern ventilators, it's much easier. It takes all the math out of it. We just simply set an I time. I time is used as a comfort adjunct. It can also be adjusted to manipulate somebody's oxygenation. But really, what is I time? It is the amount of time it takes the patient to receive their full breath. In adults, we have the starting setting of about a second, and we can manipulate that if they look uncomfortable. So you have somebody who looks extremely uncomfortable, they're taking a lot of spontaneous breaths even though they're being really well sedated. Maybe they are kind of biting on the tube, or they look like they're trying to suck on the tube to initiate breaths. Oftentimes that may not be a problem with the respiratory rate that you've set, but a problem with the inspiratory time that you have set. Patients on a mechanical ventilator oftentimes don't like to feel like they are or like they've got their head out of a moving vehicle at 20 miles an hour. They would rather feel like they have their head out of a moving vehicle at 100 miles an hour. So they want that breath very quickly, and even though that may not feel comfortable for you and me who are awake, somebody who is mechanically ventilated, that is typically a lot more comfortable. So our starting settings for adults would be 1 second. In 1 second, they are going to receive their full inhaled breath. And if they look uncomfortable, we can reduce that to 0.8 or 0.7, etc. Respiratory rate, which is setting number 3. So when we are spontaneously breathing, we need to be moving quite a bit of air in and out of our body every minute in order to maintain eucapnia, specifically 60. So 60 milliliters per kilogram per minute of our ideal body weight in order to maintain eucapnia. When somebody is intubated, that number immediately doubles because of a lot of mechanical dead space inside of the circuit, inside of the ET tube, as well as intrinsic dead space in the large airways. So if we take our 80 kilogram ideal body weight patient, which is maybe a 6'3" male or 6'2" male who has an ideal body weight of 80 kilos, they need approximately 9.6 liters per minute to maintain eucapnia. And it's a really easy number to get. You just take 80 and multiply it by 120. Remember that it's 120 milliliters per kilogram per minute in order to maintain eucapnia in our intubated patients. So we have 80 times 120, and that gives us 9.6 liters per minute, or 9,600 milliliters per minute to maintain eucapnia. So what about their respiratory rate? So we take this 80 kilogram patient, multiply it by a tidal volume that we've set into the ventilator. We say, just arbitrarily, I chose 7 milliliters per kilogram. That gives us a tidal volume of 560 milliliters per breath. So that's what we're going to dial into the tidal volume setting in the ventilator. So if we need to move 9,600 milliliters per minute, and we are breathing 560 milliliters per breath, that means that in order to get that minute volume, we need to have 17 breaths per minute set to the ventilator. That's a lot more than that 12 that we saw on the Hamilton T1 photo a few minutes ago. And that 17 breaths per minute, or that 16 to 18 breaths per minute, that is the appropriate thing for our patients on the ventilator. This is a pretty important concept because I feel like when we're learning to breathe for people on a bag valve mask, we don't breathe this quickly, right? We tell all of our students to give them a breath every 5 to 6 seconds, so they're breathing 10 to 12 breaths per minute, but that is not the same as a ventilator. We need to be breathing a lot quicker for our patients who are mechanically ventilated. So do not set and forget that respiratory rate of 12 on the ventilator. It is kind of the standard starting setting for many rural hospitals. It causes severe hypercapnia. Your patient oftentimes will feel like they're drowning, so they're very difficult to sedate, and it also increases the amount of pain and discomfort that they're feeling from the ventilator. So we need to be setting a respiratory rate of 16 to 18, and we're going to titrate from there based off of our in-tidal CO2. So do I, every single time I put somebody on a ventilator, do I do my respiratory rate calculator of 120 mLs per kilo per minute? No, I do not. I'm going to set a respiratory rate between 16 to 18, and I'm going to look at my in-tidal CO2. And if my in-tidal CO2 is high, I'm going to increase my respiratory rate to blow some of it off. And if my in-tidal CO2 is low, I'm going to decrease my respiratory rate in order to retain a little bit more CO2. So what does respiratory rate mean for our patient? It means ventilation, right? So we are manipulating our minute volume by manipulating our respiratory rate. Therefore, we are changing our CO2. The last button on the last setting on the ventilator is our PEEP and FiO2. These are partners and they need to be viewed as the same entity. Please, please, please do not leave your patient on 100% FiO2 for a 45-minute transport. It is toxic for our patient and very hard on their alveoli. You have increased incidence of ARDS with patients who are left on an FiO2 of 100%. So after intubation, it may be very appropriate to start off at 100% FiO2 on your patient, but then we need to start titrating down in order to maintain an oxygen saturation of 93 to 99%. Remember that we never ever want to see 100% SATs in our mechanically ventilated patients, because then we have no idea what the arterial concentration of their oxygen is, right? If we see an SpO2 of 100, we could have a PaO2 of 105, or we could have a PaO2 of 500, which I'm sure, as you know, a PaO2 of 500 is not ideal for our patient. ardsNet did studies back in the 90s and early 2000s, and they're still very prevalent today, and they have proven a mortality benefit for higher PEEPs and lower FiO2s. If you're familiar with ventilator settings, maybe in your hospital or wherever, I'm sure that you have seen the FiO2 of 100 and the PEEP of 5 on almost every single patient. But you can see here that this lower PEEP, higher FiO2 scale is probably pretty markedly different from what you've seen, and this is what PHI recommends. This is what we have in our clinical care guidelines policy, is this type of PEEP scale. So you can see here that we generally start at a PEEP of 8 and an FiO2 of 0.4 or 40%, and then we're going to move up this scale in tandem in order to improve oxygenation in our patient. So you have to think of oxygenation being affected by two things. The first is how available oxygen is to our alveoli. So we have 40% or 50% or 60% FiO2, that is much more available oxygen than we would normally have on room air, so that will obviously increase your oxygen saturation. However, if you do have some atelectatic alveoli, or you have fluid in your alveoli, or you have a patient who is not taking incredibly deep breaths, there are many reasons, but if you're not keeping volume, keeping air in your lungs at the end of expiration, then you are not going to be oxygenating very well. So adding PEEP is equally, if not more important than adding FiO2, as the benefits of PEEP are far and wide. So remember that our goal is 93 to 99%. We do not want our patients saturating at 100% on the pulse ox, as we don't know what their PaO2 would be. And then we are going to work up on the scale. So if our patient has an oxygen saturation of 89%, we are going to go up on our PEEP and our FiO2 in tandem until we reach our goal of 93 to 99%. PEEP is not dangerous, but it does take several minutes, so go ahead and wait between adjustments. So we're not going to increase our PEEP from 8 to 10 to 12 within a 2 to 3 minute span. We need to wait for all of that recruitment to take place, and that takes several minutes each time you make an adjustment. So the benefits of PEEP, like I said, are kind of far and wide. So we have much improved compliance. So if we think about compliance or static compliance with regards to PEEP, we can think of a balloon. So when we have a balloon that's totally empty and we go to blow in it, that first little bit is pretty difficult to get that balloon to open up. But if we give just a little bit of volume, so we turn that small balloon into maybe the size of a softball, and then we pinch it off and we hand it on to somebody else, it's going to take them much less force in order to blow their full breath into that balloon. And that is really what PEEP does in essence. So if we just leave a little bit of pressure, a little bit of opening in that balloon or in that alveoli at the end of their breath, and we don't let that alveoli totally collapse down, it's going to be much easier for that next breath to come in. So we have a marked improvement in compliance when we have additional PEEP. Another thing it does is it reduces alveolar shunt. So if you have an alveoli that's all collapsed down, it doesn't matter how much, or we have a lot of pus or fluid or whatever we have inside of that alveoli, it does not matter how much oxygen we put into the lung. If we are not ventilating that alveoli, if we are not opening up that alveoli and allowing oxygen to get into that portion of the lung where the actual gas exchange occurs, then we are not going to be increasing our SpO2 at all. PEEP also reduces atelectasis and atelectrauma, so we're going to reduce the incidence of like infection and ARDS by using PEEP. And it also makes spontaneous breathing a lot easier, which kind of goes back to that balloon model. So if you have a patient who is having to initiate breaths on like SIMB mode, and they don't have any PEEP from the ventilator, it's going to be pretty difficult for them to initially open up and pop open all of their little alveoli. Whereas if we give them 8 of PEEP or 10 of PEEP, it's going to be a lot easier for them to open it up, as all of their little balloons are already half opened or half full, so it's much easier for them to take that spontaneous breath. The only disadvantage of PEEP is that you do decrease venous return, and that's only at higher PEEPs, really. So you do have a decrease in venous return immediately when you put a patient on positive pressure ventilation versus negative pressure ventilation, which they do when they're spontaneously breathing. But when you have 5 of PEEP or 8 of PEEP, you generally are not going to see a large decrease in their blood pressure. When you do get into higher PEEPs, you may see a little decrease in their blood pressure, but we're never going to sacrifice oxygenation for a good blood pressure. So we're going to get good oxygenation because hypoxia is one of the largest increasers in mortality for our ventilated patients, especially our ventilated patients who have experienced some sort of traumatic injury. And so we are never going to reduce PEEP just because our blood pressure is not good. We're going to add fluids or pressors in order to maintain that map. All right, so I've hinted it or stated it several times, but what does FiO2 and PEEP mean for our patients? It means oxygenation. PEEP is not going to cause a pneumo in your patient. You really do not need to be afraid of PEEP. And I really cannot overstate its importance. You can see on this graph right here, this A, B, or C. With A, we have very little PEEP in the lungs, and you can put 100% FiO2 into those alveoli, but the oxygen is not getting to that terminal or functional unit of the lung, and so as that blood passes through those alveoli and the pulmonary capillaries, it's not able to pick up any of that oxygen. But you add a little bit of PEEP, and all of a sudden you're at graph B, or that picture over the top of B, and now we've got oxygen that's able to be exchanged in those pulmonary capillaries. And then you can see with C, you're really putting a lot of PEEP, 10 or 15 of PEEP in those lungs, and now you have incredibly large surface areas, you have thinning of the alveolar capillary membranes, and you have very easy diffusion of oxygen and carbon dioxide inside of those lungs. Remember that if your FiO2 is over 50% and you are not saturating well, then alveolar shunt has to be present, and the only way to solve alveolar shunt, which you can see in those pictures, is with PEEP. So historically, many people have been afraid of PEEP because they think that it's going to cause lung trauma. But really, let's talk about what PEEP is. So when you blow up a balloon, your first an empty balloon, you're blowing it up, and you get that initial huge spike in pressure because it's really difficult to open up that balloon, to initiate blowing up that balloon. We can call that our peak pressure. Once you really start to blow up the balloon, though, it gets a lot easier, right? That kind of half full to about 90% full balloon is pretty easy to blow up. It doesn't take a lot of effort. And that's what we can describe as our plateau pressure. As we let air out of that balloon, and then we pinch it off with still, 5 or 10 centimeters of water pressure left inside of that balloon, that's our PEEP. So our PEEP is the lowest pressure that we really are exhibiting on that balloon. It's it's really that plateau pressure that can cause a lot of damage. Peak pressure, which is not a very important number for us, is really just measuring the pressure inside of the endotracheal tube, the pressure inside of the that last few centimeters of the trachea, and then the pressure in the large airways. But as air travels into the lungs and equilibrates through the lung and starts to open up all of those alveoli, we end up with this plateauing of our pressure curve, and that is our plateau pressure. That right there is what will cause lung injury, because that right there is what the alveoli are actually seeing. And all we need to do is we just need to keep our plateau pressure less than 30, and our patients are going to be protected. And remember that we had talked about protection quite a bit, and now we are coming back to it. So if the P-plat or plateau pressure is less than 30, then the lung is safe. If it's greater than 30, we are at risk for barotrauma or a pneumothorax. Pictured on the right here, we can see the Ravel ventilator. This is what the majority of folks at PHI are using around the country. And in order to check our plateau pressure, we are going to perform what's called an inspiratory hold maneuver, and that's going to give us our plateau pressure, as well as our static compliance. When you check a plateau pressure, in short, if it is greater than 30, the patient is no longer protected, and we are going to have to go down on our volume, because remember that tidal volume equals protection. So if we dial in a tidal volume of 8 milliliters per kilogram and we check a plateau pressure, and that plateau pressure is 35, that patient's lung is not protected, and we're going to need to go down by 1. So we're going to go down to 7 milliliters per kilogram. And then we are going to check another plateau pressure. We're going to perform another inspiratory hold and recheck our P-plat. And if our P-plat is still over 30, then we're going to go down to 6 milliliters per kilogram until that patient is safe, until that plateau pressure is less than 30. All right, so in review, we know that tidal volume equals protection. So when we are initiating ventilation on our patient on assist control, we're going to first dial in a tidal volume of 8 milliliters per kilogram, and we are going to check a plateau pressure, and if their plateau pressure is greater than 30, we are going to go down to 7 or 6 or 5, so forth and so on. I time is our comfort dial. We're going to start at 1 second for adults, and then if we need to, we can go down to 0.8 or 0.7 if that patient seems to be very uncomfortable with that 1 second inspiratory time. Respiratory rate equals ventilation, so we are going to start at 16 to 18 breaths per minute, and if their end-tidal CO2 is high, we are going to increase our respiratory rate in order to breathe off some of that CO2. If our end-tidal CO2 is low, we are going to lower our respiratory rate in order to retain a little bit more CO2. Our PEEP and FiO2 together equals oxygenation. We're going to start off around 40% FiO2 with 8 of PEEP, and we can increase those in tandem with each other in order to attain our oxygen saturation goal of 93 to 99%. If the patient is hemodynamically unstable after adding PEEP, then remember we are never going to forfeit our PEEP to help our MAP. We are going to increase our PEEP to get our oxygenation goal, and then we are going to add fluids or pressors in order to get our MAP goal. A word about sedation. On assist control, our patients do need to be very well sedated. We need to start with analgesia. Fentanyl is oftentimes the analgesic of choice to run in tandem with any of our sedation drips, but most ventilator asynchrony is due to pain, not due to a lack of sedation. So a lot of the time we will walk into a facility and see that they just have a Versed drip going or just have a propofol drip going, and you'll find that if you add a fentanyl drip in tandem with these people, that they oftentimes will become much more comfortable on the ventilator. Our sedation medications, we have several. The most commonly used at PHI would be ketamine, and then followed by propofol and Versed. These are used to blunt the discomfort from hypercapnia and positive pressure ventilation, but the analgesia, that fentanyl drip, is going to be used to help with ventilator synchrony and discomfort from the positive pressure and from the tube. Okay, so case number 1. We are called to intubate a 73-year-old male who had a CVA and is obtunded, is not managing his secretions very well, and having variable desaturations. He's 6'1", weighs 104 kilograms, but has an ideal body weight of 83 kilograms. He was RSI'd with 2 milligrams per kilogram of ketamine and 1 milligram per kilogram of rocuronium, and was intubated with an 8.0 ET tube that was secured at 24 centimeters at the teeth. Now let's place this patient on the ventilator. So what are our initial vent settings? All right, so you've placed this patient on the ventilator now, and we are going to perform an eye hold using our initial vent settings. We look and we have an initial PIP, or an initial peak inspiratory pressure, of 31 centimeters of water pressure. We perform an eye hold and we see that our plateau pressure comes back at 18 centimeters of water pressure with the settings that you've chosen. So is he protected? Yes, he is. And we do not need to make any changes to our tidal volume at this time. Case number 2. We walk into a room due to an audible vent alarm. We see a 29-year-old male who has an ideal body weight of 70 kilograms. He was involved in a motorcycle accident. The patient is restrained, but fighting his restraints, biting the tube, and he is coughing. So what are our priorities for this patient? Oftentimes, when you walk into a room, if a patient is fighting the tube, it is due to one of two things. It is either due to pain or lack of analgesia, or it is due to an inappropriate ventilator setting that is going to make this patient almost impossible to sedate. So priorities for this patient is going to be immediately looking at the ventilator, looking at the vent settings, as well as probably adjusting their sedation and analgesia. We see that his current sedation package is that he has Versed at 8 milligrams an hour, and that is it. So what are we missing on this patient? And I would say the number one thing that we are missing is going to be a fentanyl drip in order to help with this patient's discomfort. So why is he being asynchronous? Remember that it's almost always due to pain or an improper vent setting. So we see that he is on assist control with a tidal volume of 550 milliliters. He has a respiratory rate of 12, an I time of 1 second, a PEEP of 5, and an FiO2 of 75%. His vital signs: he has a blood pressure of 145 over 92. He has a heart rate of 131. He has a respiratory rate of 15, so he's breathing a little bit over the ventilator. He has an SpO2 of 100%. What is missing in this patient? Something that hopefully should be blaringly obvious to you guys is that he is missing end-tidal CO2 on this in his vital signs. So if you add end-tidal CO2 to this patient, we see that it comes back at 56 millimeters of mercury. So what do we need to change immediately in order to make this patient more comfortable on the ventilator? Case number 3, we respond to a very rural facility for a 42-year-old female who's 5'6". She has an ideal body weight of approximately 60 kilograms. She was diagnosed with pneumonia and sepsis, was intubated yesterday after having a severe hypoxic event on med-surg, and is now being transferred to a higher level of care. You walk in the room and you see that she has a propofol drip at 35 mics per kilo per minute and has initial vent settings as follows. Mode is assist control, tidal volume of 550, respiratory rate of 12, has an I time of 1 second, a PEEP of 5, FiO2 100%, and her PIPs are 38. What are your thoughts and what are your immediate actions for this patient, keeping in mind analgesia and proper vent settings? All right, thank you everyone for hanging out with me today. If you have any questions or comments about the presentation, please feel free to reach out to me at akaiser@phirmedical.com, and I look forward to seeing you guys on part 2.